team for creating this event today and for all the work that you're doing to engage One Health across the continent. It's really great to see the enthusiasm of the team and of the participants. So let me share my screen. Let me just check that it's working. Always that moment of trying to make sure all the tech is working. Okay. One moment. Dowda, could you just confirm if you can see my slideshow or?
Yes, I can see your slideshow and you're clearly audible. Okay.
Okay, excellent, wonderful. So as Dowda has already introduced me, I'm Leon Thomas. It's wonderful to be here today. I'm talking to you from Nairobi. But I'm in the very lucky position that I have this joint appointment between the University of Edinburgh and ILRI. So I find this a really wonderful place to sit between an academic institution, a research for the development institution. So today, the topic of the 2 days that you're going to be together is really about the economics of One Health, and we're using the sort of economics of antimicrobial resistance to introduce the topic and to get everybody thinking today. So let me just quickly run through what we'll be touching on in this keynote address. I'm just going to start my timer because I have a tendency to go off piste and spend more time than I have, so I'll keep an eye on that. So first of all, we're just going to remind ourselves about, One Health, AMR as a quintessential One Health issue. I'm sure this is not anything new to any of you here today. And then probably the biggest question is, why should we really care about economics when we're faced with this really big global challenge? And we'll then go through thinking about how we're going to identify and quantify the burden of AMR across those 3 One Health domains. So considering people, considering our domestic animals, and the environment. We're then going to have a think about what happens on the converse side. What about the balance? When we think about controlling AMR, we know that we're going to we want to mitigate all those burdens that we've identified. But of course, control strategies come with their own costs and impacts as well. So we're going to have a look at the other side of the coin and then think about how we evaluate our options before we conclude. But because I have the joy of being the first one to speak to you today, let's first of all get everybody woken up, get our brains going and situate ourselves. So I've got a few questions for you. You can pop the answer in the chat. Unfortunately, I don't have any prizes for the fastest fingers, but let's just sort of think about these questions just to get us going. So first of all, what do you think the estimated number of annual deaths caused by drug-resistant infections are going to be in 2050 if no interventions are implemented? Are we looking at A, 1 million, B, 5 million, or C, 10 million? So quickly pop your answers in the chat. I'm going to give you 10 seconds and then we'll reveal the answer. Okay, I see lots and lots of 10 millions. Everybody is thinking pessimistically. And yes, you are correct. All of those who were saying C, the 10 million. At the moment, the predictions are that if we don't take action, the deaths related to drug resistance infections are going to be huge, amounting to possibly 10 million deaths. So that would bring us sort of equal to the deaths seen through cancer. So this is a really important and increasingly important issue. So the second question. Now, what do we think that the projected cost of these drug-resistant infections is going to be accumulating between sort of going back from 2014, going forward to 2050, and we think about the losses that are going to accumulate over that time, are we thinking that it's in the region of 10 billion, a trillion, or $100 trillion? Quickly pop your answers in the chat. I can see I've swayed everyone to thinking worst case scenarios. A couple of C's there. Okay, B, 1 trillion. I mean, these are huge numbers. I don't, you know, we're really looking at huge numbers here. Okay, B's and C's. Yeah, it is the worst case scenario there. A potential cumulative loss of GDP across the world of $100 trillion. And then let's think about how that loss is felt across the world. So do we believe that we're going to see an equal loss across all countries? Is it going to be disproportionate to those in the low and middle income countries? Or are we going to see it mainly in the high income countries because we have higher healthcare expenditure there? So what do you think people think here? B's and C's, okay. People think that it's going to be disproportionate, but which direction is it going to go? Well, very unfortunately, but very relevantly because of the audience that we're talking to today. I mean, you're right. Those who said B, who said C, yes, the cost of healthcare in the high income countries is higher, and that could drive loss. But actually, like so many of our health issues that we feel today, this is disproportionately going to impact low and middle income countries. And so this is really an issue that us as a community living, working within sub-Saharan Africa particularly need to be aware of. So thanks everybody for indulging me with a little bit of warm-up thinking. I hope that was just fun to just sort of put some figures in context. So now let's the infographic, which comes from my colleague Ashley Moodley. Ashley runs the AMR hub for the CGIAR. It's sort of an illustration of where drug use and drug resistance can pop up across all these systems. So we have drugs being used within small animal and within livestock animal health. We have residues and organ and potential resistance organisms traveling through the food chain to where people are eating. We've got drugs being used in hospitals, and obviously the resistant organisms occurring in the people who use those. Those people will interface with a variety of areas back to their domestic animals, back to their wild animal populations. And we also have drug production and the waste from that, which can see drug residues going into the environment, going into the aquatic environment. Those aquatic food chains feed humans, and so this is an interconnected system. And obviously, AMR it doesn't sort of observe boundaries. It doesn't observe country boundaries. It doesn't observe species boundaries. We have an opportunity for a whole system to be impacted. So obviously, One Health is a really important aspect and an approach to dealing with AMR. And because AMR is a One Health issue, we're going to have huge numbers of perspectives involved. And if we think back to the OLEP definition of One Health, one of the key principles is that we're aiming to balance and optimize health across the domains of humans, animals, and ecosystems. So if we want to get to that balance and optimization, we're going to need to balance the priorities and the perspectives of the different people involved. So this slide is really just sort of saying, we could have had so many more stakeholders here, but just if we take farmers, clinicians, parents, business leaders, and wildlife, each of them has their own perspective, their own priorities that they want to bring into this debate. So I think it's those balancing of priorities and perspectives that makes economics such a valuable framework for decision making. And that's going to be the rest of my lecture is really sort of focusing on what we sort of perceive as being those economic issues. So why do we want to use economics, and how can we look at AMR with an economic hat on? So we can use economics at lots of different stages of our work. So to start with, we know that there are a multitude of problems out there in the world today. You know, AMR is a critical issue, it's a global issue, but it's only one of multiple complex health challenges that we are facing today. So first of all, we can use an economic lens to think about what should we even start tackling, and whether, you know, should we be researching, investing our research time and energy, or our intervention time and energy in this problem or in that problem? Economics provides some frameworks to help us decide that. We can compare different indicators, different issues using similar indicators, so that we can actually start looking across problems. And we'll talk about this more. What are those metrics or measures that we can use that helps us compare seemingly very different problems? And then we can use economic frameworks to help us decide what interventions offer the best solutions to our problem. And we can do that by modeling the economic impacts of our interventions. But of course, just remember, economic analysis will only be one part of the picture. So we may have an intervention that is sort of strongly beneficial in economic terms, but it may not be acceptable or sustainable. So we will, of course, bring in lots of different criteria into our decision making. But the economic framework of being able to look at what balance, what cost and benefit is there in certain interventions is a really important step in that decision making process. And it can also really help us, and this is particularly important when we've got our One Health lens on, is who should pay for those interventions we choose. So by creating an economic framework and doing economic analysis, we can actually look at evaluating interventions from different perspectives and start disaggregating where the costs and where the benefits fall, so that we can actually look at who should pay or who should subsidize these interventions. So if we start with that sort of first issue about how do we know what issues we should be researching or investing in, well, one of the ways that we can evaluate one issue against another is by thinking about burden and assessing burden. So first of all, we're going to think about, what do we know about the burden of AMR? And firstly, I said, we're going to look across all three of the One Health domains. So first of all, we're going to think about the impact in human health. And there are various different ways that we could measure human health impact, and we'll run through a few of these now. So the first one, and often like that headline figure, is going to be deaths. So we're thinking about deaths from AMR. And this figure is from the Global Burden of Disease Consortia AMR collaborators. They published this year looking at the deaths, the burden of AMR in the world today. And they have indicated that currently we're looking at about 1.1 million deaths per year in 2021. And these were deaths that were attributable to AMR. And in the next slide, I'll look more at what I mean by attributable and associated with. But essentially, these are the ones where the resistance itself was implicated in the death of the person. In 2021, almost another 5 million deaths were associated with AMR. But it's predicted, as we talked about earlier, that this could go up dramatically, with those attributable and associated deaths coming to almost 10 million by 2050 if no interventions are are established. So I just mentioned that these two words, attributable and associated. So for this particular work, the attributable deaths were those where the people would not have died if that infection was treatable. So if the organism had been resistant, had not been resistant, had been susceptible, those people would not have died, and therefore the resistance caused their death. But it was susceptible to the antibiotics and they would have therefore lived. So that's the counterfactual here. But an associated death is one where a drug-resistant infection was implicated, but whether or not the resistance itself caused the death is not known. And this here, those deaths, so that 8.7 million additional associated deaths were additional deaths compared to a hypothetical scenario where those drug-resistant infections were replaced by no infections. So in this case, they didn't have the respiratory tract infection in the first place, not just a susceptible infection. So there's slightly different baselines here against which those additional deaths are calculated. And that's just important to have in mind because, you know, whether or not somebody had a respiratory tract infection that was susceptible or not, they still could well have died if it was susceptible. So if you're taking away that infection altogether, that's going to inflate the number of deaths there. And these are just things to think about when we're looking at those headline figures of deaths, particularly when we're comparing it to other issues that we might want to research. What are the counterfactuals? What is this being compared against? But if we take the work that has been done by the Global Burden of Diseases, and you can get into a really great website through this is the Institute for Health Metrics and Evaluation. That's the umbrella institute that hosts the Global Burden of Diseases study. They've got a great website called Microbe, which allows you to go in and look at visualizations of AMR burden. And you can see in this chart, the larger circle here is all the deaths due to sepsis, of which a proportion are bacterial, and then we've got the resistant associated and the resistant attributable deaths nested within there. So that just gives you an idea of the relative number of deaths associated with AMR versus the global burden of sepsis as a whole at the moment. Again, this is, as I mentioned, because we're thinking about frameworks which are going to help us make decisions, it's really good to have things to compare against so we can put these issues into perspective. But deaths is just one way of looking at human health impacts. So the number of deaths themselves is quite a two-dimensional sort of issue. And actually, human health impacts of AMR and other health conditions is much more 3D. We have an aspect of mortality and morbidity. And this is where we can get to a slightly more nuanced measure of the disability adjusted life year. And this is a metric I'm sure many of you are familiar with. This was developed, originally by the WHO and then taken on by the IHME to be under the Global Burden of Diseases study to allow us to really compare the health impacts of numerous health issues in a way that accounts for that mortality and morbidity issue. So this is a single measure that takes into account both of those aspects. It's made up of years of life lost and years of life lived with a disability. And that disability, years of life lived with disability, is also weighted where against a sort of a scale where 1 would be death and 0 would be perfect health. So you can get that nuance of how detrimental to people's quality of life that disease or injury is. And just to give a little bit of additional information on DALYs. Just going to run through the life course of a guy called Bob and show how the DALYs might be tallied over his life. And so this guy was born as a bouncing little baby. He had a perfect several years lived in perfect health with a disability weighting of 0, but then broke his leg. Then spent a bit of time recovering, so had a small disability weighting attached to the year where he was recovering, but bounced back very quickly with no complications, continued into adult life with a very healthy existence. But he then got a resistant respiratory tract infection, and his quality of life dropped with a disability weighting, and a year later, unfortunately, he died. And so here there would be DALYs associated with these every area where the bar falls above 0. Sorry. So there would be some DALYs associated with that instance of breaking a leg earlier in his life, and DALYs associated with the time that he lived with the resistant respiratory tract infection. And then this big blue block at the end would be the years of life lost, with the end of this graph being the current life expectancy for Bob when he was born. So there you can start seeing how DALYs can be put together in a much more nuanced measure of health impacts than purely deaths. So the Global Burden of Diseases study has estimated those DALYs associated with AMR. And in 2021, they estimated just over 42 million DALYs attributable and 178 million DALYs associated with AMR. And this was predicted to rise by 2050. What you can see is that the DALY, whereas when you look at deaths, those deaths predicted by 2050 have risen substantially. I think there was about 70% increase in deaths between the baseline of 2019 and 2020. But it's a much slower rate of increase when you look at this in DALYs. And this is due to a changing pattern in age distribution of who's going to be impacted by AMR. Oh, yes, there it is. So what this graph here is showing that AMR deaths are actually predicted to reduce in those under 5 years. And this is actually, this is a real success story, not just around the way that people are tackling AMR, it's actually thinking about what the global community have been doing in terms of reducing mortality in that age group overall. And this is around investments in WASH, investments in vaccination programs, and all of those things that are really protecting what was an incredibly vulnerable population and is now having a much greater chance of living a full life. So we're seeing AMR deaths due to reduce in those under 5, mainly for those developmental reasons that we've discussed, but AMR deaths in those over 70 years are going to increase. But what this means is that when we reflect the burden of AMR in terms of DALYs, because there are less years of life lost from those younger people, the DALY rise is slower. And at the moment, morbidity is a smaller part of this burden assessment than mortality, because people are not living for a long time with a chronic issue due to resistant bacteria. The chart I've just popped up at the bottom of the screen here is thinking about sort of leading causes of disease burden, and we can see the shift between 2022 and 2050. And one of the other reasons sort of for this slower rise in DALY burden is because actually across the world, a lot of the health burden is shifting towards communicable disease, non-communicable diseases, sorry. If you go into the IHME website. They've got this wonderful GDP compare tool. Go in, have a look at the burden of disease over time between countries. You'll see a real shift between the infectious and the non-communicable diseases. Now, that is not a good thing, of course. Means that we've got other crises. We've got an AMR crisis going on, but then on top of that, we have these non-communicable disease epidemic as well that needs considering. So, but it does mean that we have a shifting baseline of our problems and where the investment will go. So I'm not telling you about the slow rate of change of DALYs to say that this isn't important. It's just important to look at it in comparison to the other issues that are out there, because also it may be that if we want people to invest in new antimicrobials and invest in protecting lives, particularly in low and middle income countries, we're going to have to shout louder, because a lot of investment may be going into the non-communicable disease area. And as per my question earlier, we know that the burden of AMR is not equally distributed. We can see this very high sort of colored heat map here across in Africa, and that's due to increase with the burden really falling disproportionately in low and middle income countries. And I think, knowing this again is a really important reason to advocate for this as something that needs tackling now, because we know historically that we have so many neglected diseases in low and middle income countries that aren't getting the investment they need. So this is the time where we need to get investment made. So that's just one way of looking at the burden of AMR from the perspective of deaths or DALYs. But we then need to add to that. We know there's multiple dimensions of that burden, and that also includes the cost of healthcare associated with AMR. And so at the moment, this report that was published just, I think, last month by a consortium including WOA and the World Bank has indicated that the current cost of healthcare associated with AMR is around 66.4 billion, but this could increase dramatically again if no interventions are put in place, and these are huge numbers. And so this particular analysis was made up of a cost of illness study looking at the cost per resistant infection that was admitted to hospital. And what we know is, of course, those costs of hospital admissions vary greatly. Anything between $100 up to $30,000 per admission, between low and high income countries, and of course, depending on the infection type that was studied. And what I think was really interesting in this analysis is that, as well as just the cost per resistant infection admitted into hospital, they really looked at what the excess costs were for a resistant infection versus those were susceptible. And this ranged anywhere from £50,000 to £20,000. And this is shown in this chart here, that we've really got the resistant bacterial costs, and the red bars are the susceptible. You can see a really big difference here of the excess cost related to a resistant infection. And then at the moment we've got and the percentage of that healthcare expenditure. So if we think about in high income countries at the moment, we're looking at less than 1% of the total healthcare expenditure being related to resistant infections, but that increases dramatically in low income countries. So not only is this issue creating a disproportionate health burden in low and middle income countries, but it's taking up more of the healthcare budget overall, which we know is already constrained and stretched. And then, we've got the costs of healthcare, but then we've got the knock-on costs across the whole economy, and thinking about what that might mean in GDP. This should have said annual. So we had that cumulative graph that indicated that we could have up to 100 trillion lost cumulatively across 50 years. But we're looking at potentially an annual reduction of $2 trillion in GDP. And this is really from all of those knock-on consequences. So reduced workforce productivity. So that's either, so if I went into hospital with a resistant infection, I obviously am removed from the workforce. I'm not being productive. I'm not contributing to GDP. But if I also had a caregiver who was having to take time out to care for me, that's also an indirect contributor to reduced GDP. But we also, within these analysis, have aspects of reduced tourism and reduced hospitality and leisure. As people become more worried about moving between countries, they're worried about healthcare provision. But all of these aspects, these are very much about measuring. What can we measure? How can we compare different health impacts to one another? But they don't take into account at the moment the intangible impacts of these issues. And we know that AMR creates a huge psychological impact. It can create fear and anxiety around being able to obtain appropriate treatment. It could potentially lead to stigma if people were carriers of a resistant organism. Eventually, we could see, that fear and anxiety around treatment failures leading to loss of trust in healthcare and a fear of seeking care in the future. Because of the disproportionate impact on vulnerable populations that we've talked about, actually AMR is an area that is highly likely to increase the health inequality that we see across the world today. And it could also stifle medical advances. If the risk of going in for surgery is heightened because of resistant organisms, the likelihood of doing more experimental surgical procedures or pushing the boundaries may become too much to ethically do. And of course, we create many intergenerational concerns because our use of antimicrobials now and the resistance that's developing now is directly impacting future generations' ability to have effective healthcare. And these are things that are very intangible and difficult at the moment to incorporate into the analysis that has been done. So in our next domain, thinking about livestock, but also actually, many of these issues are appropriate across many companion animals as well, is thinking about what the impact is there. And again, the Eco-AMR series with this consortia here have recently produced this report, and I've got the references at the end, which I'll send around in a PDF for you to do some further reading. So in terms of AMR in livestock, well, of course, a resistant infection in livestock will have a similar outcome as us. We have mortality or morbidity associated with them. And so we are likely to see animals dying. We are going to see animals being less productive. And so at the moment, the projections are that by 2050, the production losses just due to AMR could equal the consumption needs of almost 750 million people. And this is why I've got the SDG2 sign up here, because we know that we are not achieving the goal of getting to zero hunger. And if AMR is going to then reduce our livestock productivity, we have another big barrier in the way of getting to that. So at the moment, it's predicted that the greatest production losses are likely to occur in cattle and poultry production. And this livestock productivity reduction is also going to contribute to reduced GDP, potentially 575 billion cumulative losses just due to the livestock related AMR issues. And there's been some worst case scenario modeling, so looking at potentially more AMR in livestock, an additional spillover into humans, and we could see even higher losses there. And so these predictions are compared to a reference scenario where we're continuing to use antimicrobials at the current rates, and the current resistant patterns continue. And that's modeled against a scenario where we are going to manage to drop our resistance rates significantly. And it's predominantly based on the value of the livestock lost and the production losses, but it doesn't, and some spill over into humans, but it doesn't consider other potentially more intangible issues like the animal welfare aspects of AMR. So in the similar way that I said, we've still got these intangibles that we haven't been able to quantify into our assessments. Animal welfare and AMR is something that really needs a lot of research. It's an area that's ripe for investigating. So we know that there'll be an impact on animal welfare of resistant infections, but could also be an impact from our control strategies and our reduction of AMU. So we really need more research that helps us identify the welfare issues and quantify them, and create suitable metrics for welfare into our evaluations. Dauda, I see you have your hand up, and I thought I had another 10 minutes based on your timing you sent me.
All right, then, yeah, you can take the last. Just to let you know, yeah, if we can round up a little earlier so we have time for question and answer.
Okay, all right, thank you. Sorry, I'd given myself 45 minutes to talk. Sorry about that. Okay, so we have a third sector to look at, and that, of course, is our environmental sector. And this quote from the UNEP director indicates that we've really got to think about, we can't separate our AMR crisis from all of the planetary crises that are going on. And we have many ways in which residues and resistant organisms are moving between sectors and in and out of the environment. So the environment is really important as a transmitter of of a sort of conduit for AMR. But there are also potential impacts of AMR in the environment. And this is, again, something that is not being quantified in many of the economic analysis to date. We know that the antimicrobials themselves may be impacting biodiversity and hence ecosystem function. And we really need to find ways of being able to incorporate these. One of the ways we can do that is through valuing ecosystem services. And ecosystem services are essentially an anthropocentric way of looking in the environment, but it's a way of understanding what the basic services that make life possible for people are, that the environment provides, and valuing them using willingness to pay techniques. And this can help, if we can really capture these ecosystem service impacts of AMR into our evaluations, that will really sort of bring us forward to a One Health framework. I won't spend too much time on willingness to pay, but essentially this is when we've got a non-market good without a price, and we can use various techniques to either see how much somebody is willing to pay for it, or potentially conversely, how much somebody is willing to accept in compensation for a risk. So I said, on the balance of things, we've got our burden, but we also have the costs related to control. And we know that there are various key interventions within human health, including investment in new antimicrobials, improving healthcare and antimicrobial stewardship, vaccinations, and WASH infrastructure. And these come with investment costs. So whether that's in personnel or diagnostic techniques, or in the potential for indirect costs. So that might be delayed treatment because you've got someone waiting for a culture and sensitivity test, or potentially even increase healthcare utilization because people are having to have more diagnostic tests before they're able to be treated. We know that there are costs involved with that. And in the same way, there are costs involved with reducing AMU on farm. And we know that some of that may be around reduced productivity. So either because of mortality or morbidity because of an infection, or in reducing the potential for using these as growth promoters. And there may be increased production costs due to our adoption of our mitigation methods, as well as investment needed from governments in terms of creating the infrastructure that can allow us to have better antimicrobial stewardship. And what we're illustrating here is really about what the differences are. If we've got the costs of different technologies and the potential changes in a farm's profit, there may be some changes that are actually cost negative to farms, and we can actually see them adopting them themselves. But we may have on the red side various interventions that actually negatively impact a farm's profit and will require additional support or legislation or incentives to be found to encourage adoption. And so some of the ways that we can address the concerns relating to the costs of antimicrobial stewardship would be by offering financial incentives such as subsidies, looking at the non-tariff barriers to trade. So this might be trade trade barriers put in place for different countries based on their health status. But also we may find that there are opportunities for increasing price premiums. So the illustration here is no antibiotics ever chicken, getting people's understanding consumers' preferences and putting in price premiums can support farmers' ability to adopt antimicrobial stewardship and biosecurity interventions. Then lastly, when we're thinking about those costs, we've identified the barriers, the burdens, which are the potential benefits of mitigating AMR. We've identified the potential costs, and then we can actually bring these together into using an economic framework such as cost-benefit analysis to really understand what the overall impact to the economy is from adopting these measures. And there were various scenarios that were modeled by the Eco-AMR project, including, and here they looked at better treatments of bacterial infections, but also improving access to new antimicrobials. And even though there were costs involved with rolling out these interventions, as you can see in the yellow bar at the bottom, the benefits, both in terms of reduction in health costs, reducing the human deaths, and they actually monetize those human deaths by converting them into a value for statistical life, and the macroeconomic benefits across GDP performance showed that there was a 28-to-1 benefit to cost ratio of adopting the interventions that they model. So investing in new drugs so that you can improve the access of antimicrobials and better management of bacterial infections, both of them cost, but you've got a huge return on that investment of 28-to-1. And again, livestock as well, we could see if we reduce global animal antimicrobial use by 30%, we could actually increase our GDP by 14 billion. And so and if we reduced it even further, again, we could see even more economic gains there. So there's a really strong economic argument for investing in AMR. And many things have been done to date. From the 2016 UN General Assembly, we've had the national action plans brought into place. We've seen progress with antimicrobial use falling and vaccine uptake in livestock really increasing. And very recently, in September, the last UN General Assembly high-level meeting on AMR created really strong targets. They want to see a 10% reduction in deaths by 2030, but to do that, they want to see 60% of countries having fully funded national action plans, increase the number of countries where we've got basic requirements for infection prevention and control, and a slightly non-measured but important aspect to continue to reduce the quantity of antimicrobials used in our food production. So just to conclude, the use of antimicrobials and antimicrobial resistance is a balance. We know that antimicrobials are essential, and we know that reducing their use is going to have costs. But we also know that resistance is detrimental, and there's huge costs involved with the business as usual scenario. An economic framework is one way of looking at both sides of that seesaw and bringing it together, and really can help us get towards that goal of One Health, where we're balancing and optimizing across all of our domains. So there's our key resources, and I want to acknowledge all of my colleagues at ILRI at the University of Edinburgh and our funders. And I will end there. And I'm sorry that I got the wrong time frame for my talk, Dowda, but thank you for your patience.
No, I mean, that's absolutely fine. I mean, I didn't want to interrupt because I was so enjoying it myself, and there was a lot of information in there, and I think yeah, it's a very good thing also for the participants, and they have a clear view on what the burden of AMR looks, especially on the continent. This is local, and it's more impactful that we have in the perspectives from the grassroots. Thank you very much for that explicit presentation. I mean, I enjoyed and I learned a lot, and I believe it's the same for everyone. Yeah, you took so much time to put up the presentation and to explain. I don't think there's any question, but we can take just one question before we go to the icebreaker session. And yeah, as we announced during the call for registration, this is definitely going to be participatory. So at the end of the day, we have a 1L case study session where everybody will be in a breakout session to talk to other participants about the case study they must have received in their email. So stay tuned and look out for that. Do we have a question for her? If you want to ask a question, you can request you unmute yourself or type the question in the chat box. She will answer one question and we'll move on to the next program. Thank you. Yeah, she will also share the PDF with. Oh, thank you very much. So this is a gift from her to all of us. She will be sharing the PDF that she mentioned in the presentation to us. And there's another gift at some point today. But yeah, let's take this one first. Thank you so much. Well, like I said, I don't assume there will be questions because yeah, you took your time to make everything clear. Thank you very much. So the next one will be the well, we hope you'll be here with us tomorrow, Dr. Lian. Okay, yeah. But if not, we understand how busy your schedule is and everything you have a tend to do. But yeah, thank you so much for taking the time to put this together and to present. But then what we have planned is if you have any questions that you want to ask, and because of time, we can't answer them right now, or our presenters can answer them that right now, you can send them to our email. When they have the time later in the year, they can put up responses and we can share with everyone, since this is an ongoing thing. Thank you. So for the icebreaker session, my colleague Marilyn Muti will be the person handling that. Marilyn, are you ready?
Yes, I am.
All right, go ahead.
Hi, everyone. I don't know if my video is. Am I audible?
Yes, we can hear you.
Yeah, hi, everyone. My name is Marilyn Mube, and I'm a food scientist from Kenya. Thank you so much, Dr. Lian, for the wonderful presentation. So for this session, we're going to do something a bit fun, and I'd like to ask I've seen we are well represented. I was checking in the comments and I saw we have people from Malta, Portugal, Ethiopia, Kenya, Nigeria, Namibia, name it. So now my question to you is going to be this. I'm new in your country and now you're tasked with the opportunity to show me around. What is the one food you'd take me to eat? And it's going to be very interactive. I'd like you to, if you've had your country, please raise your hand and tell us what interesting food would you want me to try?
All right. Before I type my own, I mean, I have a long list of food to send to you because there are many nice dishes in Nigeria. But before then, we should pay attention to the chat box. Dr. Lian is reminding us about the SOSB One Health Fellowship in 2025. Please, well, one of the benefits of attending the dialogue, uh, do well to apply, and yeah, give them a tough time selecting the winner this time around. Yeah, thank you. Oh,
Okay, I'm
so
listening. So let's start with Dauda.
yeah,
Okay,
okay,
let me make it interesting. Let's narrow it down to a street food, specifically street food.
okay, yeah.
Yeah.
Nigeria, we have amala and begiri soup. I'm going for that, so it's not.
Please tell us who don't know what amala is. Tell us
Oh,
what it
all
is.
right. So yam flour is more cells made from yam flour. And then there is bean soup. You cook beans so much that it becomes very soft, and you add a lot of seasonings, and it becomes a soup. And when you take it to yam flour morsel, oh my God, I promise you will bind your fingers, or if you're using a fork, well, don't use a stainless fork because you're gonna hurt your teeth. Okay.
Interesting.
Oh, Dr. Shield said I read his mind with the amala thing.
Amala. So
What?
Nigeria is represented unless someone from Nigeria wants to tell us something different.
Yeah, well, Nigeria, I can sip on the jam, which is also good. But why are the Kenyans, the Ethiopians, and the
Kenyans, please do
um,
not let me down. I'll start
yeah.
mentioning Priscilla, please.
Oh well, I will. Oh, smocha in Kenya. Well, why not chapati?
Yeah.
I think I like
Okay.
chapati.
If you're not able to speak, you can also type it in the comments, but I'd really like someone to speak. So if you're from Kenya, and as a Kenyan, I'd really like someone to make us proud. We already have smocha, something different, someone else.
Oh well, Dr. Lian is voting for chapati, just like myself. So I think the chapatis, the non-Kenyan people are having it here. Since the Kenyans don't want to talk.
Yes,
Yeah.
chapati is amazing. Okay. Dr. Hector, please feel free to unmute and tell us.
Yeah, I'm gonna vote for as an Indian Kenyan, I would say you've got to try chicken tikka if you're in Kenya or in India. So that's my go-to food.
So how is that made? For those
Well,
who
it's
may not know.
right. So chicken tikka is just cubes of chicken marinated in yogurt and an Indian spice, and then it's grilled. So it's very delicious.
Ah, great. Thank you.
Thank you
Ethiopia,
very
I
much.
saw someone from Ethiopia. You can raise your hand or unmute if you're willing to speak.
Someone said ugali and mursik. That's from East Africa, I guess.
Yeah, I think Kenya.
Yeah.
Mursik is from Kenya. I'm saying Rolex in Uganda. Rolex is amazing, I should say. It's chapati, and then now you put fried egg inside it. You roll it.
Oh, fried egg inside chapati. I've never tried that.
Yeah, it's amazing. You should try it. So we
Sure.
have tikka, chapati, smocha, Rolex, amala. What else? Does
Stamaki.
ugali really count as street food, though? That's a whole meal. But anyway, it's okay. So someone else, Ethiopia, I'm still waiting. Yeah, Dancing is saying I need to try all these foods. You're welcome to Kenya. We can show you around for the smocha and chapati. Oh, I'm seeing from Ethiopia tips. Demeke, are you able to tell us what TIBS is? Are you in a position to speak?
Demeke, please feel free to unmute yourself. Or request to unmute if you can't. I just all right.
Yeah,
Thank you
welcome.
very much. Thank you very much. I think this is a special food in Ethiopia. It is prepared by meat, which means the cooked meat, especially like slightly cooked meat, the beef meat. This is
So it's just meat.
Yeah, slightly cooked meat, not deep cooked meat.
Okay.
Oh, okay, interesting. All right.
All right. The people from Cameroon don't want to tell us what we should try when we are in their country.
I saw some people from Portugal, India, Malta.
Orange.
Tell us,
Orange.
please.
Well, the Nigerians are overtly represented. Well, and don't be offended, statistically, one out of every 5 African is Nigerian. So that is what is reflecting here. So sorry.
I guess if the other countries are shy, we can have like 3 more Nigerians tell us something different. Nigeria, someone? Let me check the comments. Oh, we have someone else from Ethiopia. Mabarawe. Am I saying it properly? Mabarawe. Dak, are you able to speak to us?
Yes,
Yes, please tell us what that is.
thank you. Yes, Mabarawi is a Ethiopian name. It means a mixture of different kind of vegetable, meat, with one dish, like injera. It's in one injera. There is different type. It's a different type of stew, like that of the what they call potato, meat, it's meat, different type of the stew with heat, with one soup, with one injera. That is, if you taste, very delicious. Exactly. That means you have to hit all food within that one dish. Well, one dish.
Oh, wow. Okay. Thank you. Thank you so much. Mabarawe.
Mabarawi.
Thank you. Senegal. I hope I don't butcher your name. I'm seeing Abu Diop. You're telling us you eat here? Is it here? If you're able to speak, tell us what that is.
Yeah, hello everybody.
Hi.
How are you?
We're fine.
Yeah, it's kep.
Okay.
Kep. It's rice with fish.
Sorry,
It's our national meals. It's the national meal that we take at lunchtime.
So how is it made?
Meal. I said meal.
All right, thank you very much.
Mhm.
Thank you so much, Marilyn. In the interest of time, let's proceed to the next session. And that was interesting. It's fascinating to know someone from Senegal is willing to tell us how to make the food in their place. Kenya, Ethiopia, thank you, everyone. And
Yeah, thank you so much.
yeah, should I say thank you to Nigerians? We are we are all over the place. Yeah, so for the next session, Dr. Shio will be presenting on the business case for One Health. I mean, this is the point, especially for early care researchers. How do we, make something out of everything in such a manner that it will all make sense, not just to the the end users of the project, of the research that we're doing, but also to the people that are undertaking these, and how would these projects be sustainable on their own. So Dr. Bolanle will be introducing Dr. Shiu Shamsuddin, and then Dr. Shiu, the floor will be yours. Dr. Bolanley, are you there? All right. Dunsin, can you take over? I think Dr. B is currently busy. Dr. Witayo Dunsin, can you?
Okay, can you hear me?
Yes, we can hear you loud and clear.
And you can see my screen?
Yes, we can see your screen. Yeah.
Okay, yes. Good morning, good afternoon, good evening. I don't know what time you're joining us. Today, I'll be introducing, I think, a seasoned professional in the One Health industry who is going to be talking to us on One Healthpreneurship business case for One Health. Dr. Shamsuddin is a veterinarian and a social entrepreneur with over 15 years of experience in managing animal health businesses and projects. He's also the co-founder of Ambivet Consult, an innovative and rapid growth company supporting thousands of older farmers in Nigeria with quality livestock inputs and advisory service. That's a great work you're doing there, sir. And in 2020, just in the peak of Corona, he led the organization to implement the PPP, popularly known as the Private-Public Partnership intervention with the Kaduna State Ministry of Agriculture. And they were able to reach over 45,000 rural farmers across the state. He has also led the implementation of market-driven model for community-based animal health workers initiative, which has grown to a network of over 100 community-based animal health workers serving more than 200 rural farming communities in Nigeria. Dr. Shehu holds a specialty fellowship diploma in private veterinary medicine and public health, as well as a master's in veterinary public health. He also has a diploma in innovation and entrepreneur finance from the Kaduna Business School, certificates in entrepreneurship from the Enterprise Development Center, Pan Atlantic University, and also a certificate in management from the Nigerian Institute of Management. He is a fellow of the Akumen Academy, a global network of social innovators and change makers, solving the problems of poverty and industries. Before I tell you what he does with FAO, in 2018, his work with livestock farmers got him an opportunity to be invited to a VVIP meeting with then the Prince of Wales and now the King of England, King Charles, while on tour to Nigeria. In FAO, he is a consultant. He was the country director for the project Sustainable Business in Animal Health through the training of veterinary paraprofessionals. He is now joined the project's global team as animal health business specialist in a consultant role supporting project implementation in Nigeria, South Africa, and Uganda. So I believe he is the right person to discuss One Healthpreneurship. So if you're not yet with your pen and book, I think you should get it, and let's begin. Over to you, to Dr. Shehu Shamsuddin.
Yeah, thank you very much for the introduction. Can you allow me to share my screen? Okay.
Yes, you can share your screen now, sir. You have 30 minutes, sir. Yeah, just a quick reminder. We have exhausted our
I hope
15
not.
our
I'll
15
try not
Okay.
to spend up to 30 minutes. I think so that if there are one or two questions, we can also take. Thank you very much for inviting me to this very, very, I'll say, revolutionary platform. I was here last year and I've seen a lot of improvement in terms of how much impact we have been able to make. I hope this is going to be sustained. So thanks also for, Leanne, for that very wonderful introduction and background. And this, kind of reaffirm, why we definitely need to rethink, how we approach One Health, especially from the solution perspective. If you think about AMR as just one, like one out of, many hundreds of challenges, within the One Health spectrum. It's then further, allow you to think, to appreciate the fact that one way of like governments or NGOs, the traditional way would not probably be able to take us to where we're going to if we look at the statistics around, the expected death for AMR due to AMR, maybe, in the next, 2 decades. Look at a lot of emerging zoonosis, global, climate change. These are all One Health related issues. And it means that there's like a lot of responsibilities on us as, leaders or future leaders, especially because I'm addressing African youth. This is an African youth, platform. And that's why I've talked about, so how can we begin to think and leverage and borrow from entrepreneurship or from the entrepreneurial world and bringing this, some of the tools and framework and mindset into the advocacy or policy or awareness about One Health, even though much still needs to be done. But I think it's time we start talking about how can we, in our little way, start solving these problems in small, become something big, and then it becomes a revolution. So that's why we're going to be talking about this. So I won't bother you about defining One Health. You already know what it is, I assume. It's to me, One Health, it's just an approach that calls for collaboration. It's no more a concept, but it's a mindset. One Health is a way of doing things that I see it, and it's bringing, with the consciousness of the fact that human health, environmental health, and and animal health are interconnected and related. So the problems are interconnected. So the solutions also, by implication, have to be interconnected. So bringing us to One Health and entrepreneurship, what do we mean? I think I already mentioned that it's just trying to see how we can leverage entrepreneurial approach to creating solutions that benefit all domains of health, talking about health, environmental, animal, and human health. And so it's innovative approach because it's bringing to, I'll say seemingly different, models, but making it one and creating something. But basically what is the bottom line and what is something that is common between the One Health, thinking and also entrepreneurial thinking is that word collaboration. And I want us to note this as we go along in the presentation. So when we talk about entrepreneurial mindset, it's a mindset that that allows you to to want to solve a problem in a way that it's profitable, just like Dauda said, and also impactful. So again, but this mindset actually like consists of being creative, like having the mind to innovate, to try out new things, to play around with things, to be open to failures and testing. It requires resilience also, like global health challenges are huge, they're complex. There will be a lot of failures when you try to, to innovate or to solve a problem. So your ability to bounce back and not be deterred, your stubbornness, in quotes, stubbornness for success or quest for success is one thinking that I want One Health, advocates to imbibe adaptability, ability to change, to adapt to changing the problems of public health problems emerge and re-emerge, and you're having issues of yesterday are different from what you're having today. So ability to consistently adapt your thinking or whatever solution or your approach, ability to be open-minded and being able to change course or change your approach or change the way you do your things. I think it's one key mindset that we need to imbibe, and passion for solving complex problem. One health is a typical example of a complex problem. In innovation, it's called a wicked problem. Most times, wicked problems are complex, they're connected. They don't have just one way of solving them. They require a lot of collaborations. They require a lot of energy, resources. So having that passion, I think, talking as an entrepreneur now, that passion is one thing that you cannot do without. Otherwise, along the line, you just get, disinterested, and then you drop the challenge. So, sorry, internet. So, why do we need One Health? One Healthpreneurship? I think I followed the One Health movement for a while now, right? From while I was in the university, early days in universities, and the issues continue to grow day by day. 2-3 years ago, we had a global pandemic, COVID-19. AMR is still a big issue, continues to become a big issue. Environmental pollution, climate change, food insecurity in many parts of the world, including Nigeria, where I'm joining this call from. So this calls for like a creative and business-oriented approach and solution. And while it is good to advocate for government to invest in One Health, invest in AMR, invest in that, there has to be like deliberate effort for we as citizens, as individuals, and entrepreneurs to also play our role. And entrepreneurship offers that, that liberty of already starting doing something that, and then the government, when reading my citation, it was mentioned that we had a public-private partnership initiative that revolutionized the way vaccination services are being done and increased coverage for vaccination against transboundary animal diseases. It didn't just happen overnight. It took an entrepreneur or business entity that sees the problem, that sees the opportunity, and started something. And then it was easy for the government to come in and say, okay, we can partner, we can, share resources, we can share costs. And so this business-oriented approach is one of the things that I'm challenging us as African youths to, as we think about the numerous problems or impacts of One Health and One Health issues, we also have to immediately start thinking about how can we use business or the power of business or markets to begin to create solutions for such problems. So, and this is not new, with the fact that entrepreneurship or entrepreneurs have really contributed historically to the global development, whether it's in, public health, or it's in food security, or it's in environmental health or environmental entrepreneurship. There has always been, one entrepreneur movement or the other that has shaped the way, shaped the development in different sectors as we have it today. Consider, for example, Industrial Revolution was responsible for bringing advancement in sanitation, improving urban public health, and thereby helping to control, and even eradicate in some places diseases like cholera. Before, private sector organizations began to invest in public-private partnership with governments in strengthening urban water system and so on. Cholera was a very big issue in most parts of the world. The Green Revolution, following World War II, many countries, especially in low middle income countries, had very serious issues of food shortages. For collaboration between government, entrepreneurs, and researchers led to development of high yield crop seeds, fertilizers, improve agronomic practices, and some of these really impacted and helped to improve productivity and income and solve the problem of food shortage in some parts of the world. If you talk about pharmaceutical revolution, we all today have the liberty of being vaccinated against COVID or pox or other diseases because some scientists actually took time to discover, like for example, the smallpox, which is a classic example of a disease that has been eradicated. It took researchers to find vaccines, develop vaccines, but it also took the entrepreneurial, I'll say, support of businesses to make sure these vaccines are produced massively and distributed and then become becoming more available and thereby increasing vaccination coverage and immunity. So eradicating many diseases. Think about penicillin, discovery of penicillin by Fleming, and then what happened when manufacturers, farm companies came in to further develop this product and make it available. And today we are able to have antibiotics like penicillins and others to control infectious diseases. So this is also one example. And then in environmental, one typical example is insecticide treated mosquito nets and controlling mosquitoes and thereby also reducing the incidence or the risk of malaria in populations. The tech revolution has opened up space for a lot of innovation, from telemedicine, to applications for rapid, diagnostics or disease diagnosis. These and many more are showing us that the power of, entrepreneurship. So again, but what are the gaps in what I've seen in the current One Health approach? And as entrepreneurs, when we see gaps, like we see opportunities, like sounds very, contradictory, but we see gaps, you have to see opportunities associated with those gaps or those challenges. So they're still limited, despite all efforts by intergovernmental and governmental organizations, they're still limited cross-sector collaboration. And so what advantage does this or opportunities does this have for entrepreneurs? Digital platform for real-time data sharing between health, environmental, and agricultural sector. This can be like a breakthrough that will have impact, not only monetary impact, but also a lot of social impact. Insufficient funding and business model. We need to begin to think about sustainable revenue models to solve some of these, challenges, using One Health approach. So having for-profit businesses focuses on ecotourism or supporting conservation. One of the work that I think Dauda was doing in campaign against consumption of wild, trade and consumption of wild animals. At some point, he was talking about the need to, asking people to stop this practice because it's environmental impact and, public health impact. Can we think about other livelihood, like getting alternative sources of livelihood for these people, a public health positive and environmental positive business model that will enable people to make livelihood and therefore, abandon the old practices that are strengthening public health. So some of these models, thinking about this in a way that there's incentive for players, it's one way of, of unlocking opportunities. Limited access in low resource settings. We still have a lot of challenge accessing both human health, animal health services. So innovating around mobile clinics for zoonotic disease control, monitoring, vaccination opportunities. On the side of technology and data, even with the revolution of the internet, we are still not able to leverage opportunities enough. And there's opportunities for AI and IoTs for disease tracking and environmental monitoring. All we need to do is to find solution, find the appropriate customers, or whether it's government or NGOs or even individual organizations who can use this data that we're collecting of course, in a legal way, and then that's a business opportunity. Lack of awareness and engagement. There's still a lot to be done in terms of awareness, thanks to organizations like One Health in Action Initiative and all the other global organizations like the FAO and WOA and the WHO. But at local level, at our own, small micro level, we need to do a lot in seeing what business opportunities can come from, creating awareness, educational applications, organizing campaigns, together with, government or NGOs on personal health actions can be. So another challenge is inadequate risk management. We need to also leverage technology to be able to predict. So one of the goals of One Health frameworks is to be able to predict and of course mobilize early detection or response in global health emergencies or disasters. So being able to invest in technologies or systems that enable us to not just wait for when there's a pandemic or an outbreak, but be able to anticipate and therefore put risk measures in place. It's an opportunity for incentive for private sector. I've said this from what I've seen, and I beg to be corrected if I'm wrong. I have not seen enough, deliberate mobilization of private sector, incentivizing private sector to really come into the One Health space and join other collaborators in solving some of these challenges. So there's need to incentivize private sector certification, funding incentive for health and environmental initiatives. These opportunities open up for private sector organizations, would encourage them to come into the space and create solutions. Scaling successful pilots. There have been some successful pilots, but there's need for partnership models for adaptation and scaling. We can borrow from different sectors. And one thing about innovation, you don't have to create things from scratch. You can borrow from successful models and see how can this be applied to solving a typical One Health challenge. So here we come to the issue of so we have seen that it is possible to use entrepreneurial approach or mindset to challenge ourselves to begin to create solutions in our own local communities, in our states, in our countries, and then it becomes like a global, product or service. WhatsApp is a typical example of like a revolution in how we communicate. Almost everybody, like every adult, has a WhatsApp. Have you thought about like the power of entrepreneurship and collaboration and mobilizing people and solving problems in a low-cost manner? We're going to see other innovations that I think we can borrow from. But so entrepreneurship, how there are different frameworks for developing an idea. Like you have an idea, you have listened, you are worried about the statistics that the previous presenter presented about AMR and the body. So it starts from sometimes having this pain, and saying, look, we need to do something about this. So that can be a challenge, like AMR is a challenge, zoonoses, challenges, environmental issues are challenges. So think about a challenge, identify a challenge within your location or where you're interested in. So this is like step-by-step model. If there are different models, but this is just something that I think maybe can fit into this discussion for today, but it's simply you just moving from idea to action, which is the essence of this presentation. We want to move from ideas, from issues, problems, from challenges to solutions, sustainable solutions. So if you identify, let's say, a challenge, and the next step is for you to begin to ideate. So these are the challenges that I've identified within my locations, and these challenges have One Health implications, meaning either implication human, environmental, or animal health, or a combination, like, an effect on all of these different streams. The next step is to begin to ideate solutions. So what are the possible solutions? This is more like a level of brainstorming. You really don't have like, this is the actual solution. Oh, can the solution be a public enlightenment, product? Can the solution be, in collaborating with government to create vaccination, campaign? Can the solution be, around, think about different ideas that they can help, that you think will be necessary, and then you now go back and validate the need. So if you, sorry, it's more mixed up. So after identifying the challenge, you want to validate the need. So you are not there to solve all problems as an entrepreneur. You need to validate that, this, what you think is a problem, is actually a problem to others. And those people are your market. Those are your potential customers. So you need to go back to the field and validate the need. Say, okay, is there a need for this solution? Like, we have seen that there's a problem with, let's say, accessing, for example, vaccination for rabies in our community. Then you validate the needs. Like, is this need, are people willing to actually pay for the services? Are people really worried about this problem of rabies? Like, you need to go back to the field, do focus group discussions, you can do online surveys. Here you're gathering data from potential end users of your solution, and you're trying to find out how really big is the problem? How serious are they taking the problem? Are they really affected? Are they looking for solutions for this problem? And then you go to the ideate solution step, which is you trying to gather different kinds of solutions, and then you are brainstorming. And then that's not the end. Then you move on to market research, which is you going back again to now see, who are the real customers? Who are the people that can pay for these services? How many are they? How big is the market? Who are other people doing similar things, meaning your potential competitors? Like, you want to have like a bird's eye view of what the market is for this solution. And then you develop business model. Here you're looking for how to generate money from the solution. Do you want to create a solution that is going to be pay as you go? Maybe you use a subscription model, or it's going to be something that people just pay once off and then they have the product. Is it going to be like, what are the different ways? Is it going to be a product, a tangible product? Is it going to be a service? And how do you charge for such service? So in entrepreneurship, you definitely need to answer the question of revenue stream. How do you want to generate money from this while also creating impact? And then if you have identified your revenue model, then you prototype. So if you have like a solution in mind, you don't like create the solution in full-fledged. You have seen that people who, most of all, use smartphones, we know that you have an application, and then next year the application is updated, many more features are added, some features are removed. So you prototype, you just create a simple model, like a smaller version of what you want to create. And then you take it to the market, you allow people to use it, they pay for it, they give you feedback, and then you adjust based on the feedback from the market. And then you begin to scale, meaning you are going to now replicate at a larger scale. Maybe you're in a particular location, let's say you're in Abuja, your market is in Abuja, your customers are here, but now you want to expand to Nairobi, you want to expand to Accra, you want to expand to Addis Ababa. But yeah, this seems a bit abstract, and that is why the next 10 minutes, we are going to look at a practical example of a One Health challenge and how we can use this model to create an idea that's sustainable. So look at this picture very well, and this picture is I'm sure it's typical of most states or even countries in Africa. This is a poultry slaughter slab versus processing plant. Here, it's in the live bird market where a section where poultry are being slaughtered, and then they're being defeathered, processed, and cut into different pieces, and then customers come to pick them up. So if you look critically, I give you like maybe 1 minute to really look at what challenges can you see here, what public health or One Health challenges and opportunities can you see here. Traditional poultry slaughter practices, as we know, like lack hygiene. There's risks to public health through foodborne diseases, because the people here, look at them, they're not using gloves. When I went to take this picture, some people were actually eating. Impact on animal welfare. So close to where, I don't have the picture, but very adjacent to this place, there are cages where you have live birds that are yet to be slaughtered. Those are meant for sale. Like people just come buy them, and then they don't have to slaughter them. Some take them home to grow them or also slaughter them. So there's risks for animal welfare. Impacting animal welfare and health. And also there's a very huge environmental pollution situation. Look at the feathers, the blood, feathers, there's no proper drainage. And all of these things are happening, just in one location. So let's take this as an example of a challenge. So because sometimes it can be tempting to think about this One Health thing as one big abstract stuff, and you end up being like really being discouraged somehow that, oh, this is not something I can do. But when you think about them in terms of what happens in your environment, there are One Health challenges every day. So let's look at how we have used this step. So need validation. Remember, we said you're going to validate your need. You take feedback from farmers, from veterinarians, from local health authorities. Remember, you are using this One Health thinking, collaborative, interdisciplinary approach to solve a problem. So even where you're going to validate the needs, not just people paying for your services, but also other, potential collaborators, public health authorities, farmers, people working in the slaughter slab. So in this case, we found out that there's urgent need for clean, accessible water slaughter facilities to protect people and the environment. So solution concept, like trying to think about ideated, and we discovered that you can design a small modular hygienic poultry slaughter slab that enhance food safety, that can minimize environmental waste, and also is affordable. So market research, when go back to the market, you do local survey, and you are seeing strong demand. There's really demand. There are a lot of people who are willing to pay to use a slaughter facility that is clean, that is hygienic, in your region. So this has kind of confirmed the viability. But again, you need to go back and check about the revenue. How is this going to pay, let me say, your bills? Revenue generation through a pay-per-use model. So we've seen that many of the feedback indicated that people are ready to go in the slaughter facility and pay per hour or pay per number of animals slaughtered and dressed. And you can have partnership with food safety organization and local government authorities. And then the next step is to prototype. Prototype was tested in this case in the communities. A prototype that has a simple, clean, washable, slaughter slab with proper drainage was what was adopted, and it was tested. And based on the result of the testing, and then this solution was expanded, modular kits was replicated in different places, and with partnership from government to roll out the adoption. So this is a typical example of how probably you can think about from ideas to product. And it's not as linear as I put it. Sometimes you have to go back, steps backward and validate certain things and come back. But overall, at the end of the day, there's improved food safety, reduction in zoonotic disease risks, lower environmental contamination. And, so scaling it, it will be the next thing across different regions. So this is an example. And so I don't know I know there's going to be questions, but if you allow me, how much minute do I have, Dauda?
Yeah, 5 more.
Okay.
Expensive.
So what are the takeaways from this model? I will just do that and then take question. Well, from this model, you have seen that you can actually improve public health, environmental health, and economic gains. You have to underline that, and economic gains, because as an entrepreneur, you're doing this at the end of the day to be able to make profit at least, or at least cover for cover your operational costs. There are different types of entrepreneurs anyway. Social entrepreneurs, even non-profit businesses can use entrepreneurship approach, but basically at the end, it should not be something that is free, because the people who go there to sell their animals, to slaughter, are also in business. They're also making money. So why don't you have them make more money in a cleaner, safer environment, also protecting their own health, and while also getting something, having incentive for you to continue. Scalability shows that there's potential for scaling similar solutions. So if something has worked in this region and you do market research in another region that has similar maybe demographics or similar challenge or result, that can be scaled in somewhere else. And then impact, and you do look at how public health and business and farmers and local organizations have collaborated in a way to solve this public health challenge. So that's what entrepreneurship can do for you. So how do you become a One Health entrepreneur? There are a lot of things. I've mentioned some of them before. You must have vision for impact. It must be beyond money. It must be beyond money. It has to be a bigger goal, which is impact. Of course, along the line, you should be able to earn something decent in a legal way. Interdisciplinary knowledge, you need to think beyond just your own veterinary space or human health space or environment space. You need to be able to read and research and collaborate with people across sectors, but also use business principles. Problem-solving skills, we have mentioned that before. You have to become a lifelong problem solver, and creative thinking, also developing innovative solution. Collaboration, I've mentioned that you have to have a collaboration. Most entrepreneurs, they don't set out to solve problems just by themselves. Like, they use the power of network and collaboration and get the best ideas and then work on it and then be able to develop some resilience and adaptability. I've talked about this earlier. Business acumen. So One Health entrepreneurs or One Health advocates or enthusiasts, I think it's time to invest in business knowledge and business skills development, because that is going to really take us a long way in helping the world, solve different problems that are related to One Health. And then you have to be ethical in all what you do. You have to commit to ethical practice and social responsibility. And not just because you want to make money, you create solutions that are going to be of environmental or human or animal health impact. So I think no need for this. So innovation is essential, collaboration is power, impact is gold. So this is where I'm going to stop. This is the future of One Health in my own thinking, having entrepreneurial, mindset and solutions coming into the One Health narrative. This is going to help the world to live like a healthier and wealthier, world. Thank you.
Thank you very, very much, Dr. Shiu. I mean, it's as expected. This is fascinating. it's very nice to know that the one is not just something you only create awareness for, it's something that can be operationalized in a sustainable manner such that you also make economic sense for yourself, for the end users of your products, of your services. And yeah, it's all about sustainability. And this time we're talking about operational or say, financial sustainability. Thank you very much. We'll take a couple of questions, then we'll take Dr. Laura Khan's session. Somebody said the term one entrepreneurship is new. That he has never heard about it. And then what is the reference for it? I will need you to answer that question.
I must say that with all sense of humility and responsibility, that this is the first time anywhere this word will be used, published. I've also spent sleepless nights trying to find this word, but it was just my thinking, and having been an entrepreneur and been following the One Health narrative for long, it was just an aha moment for me. I just thought, well, why don't we have like One Healthpreneurship? But I know that in vets, we have veterinary preneurship, like it's an emerging concept. There's healthpreneurship, but One Health preneurship, I think you can quote me as a reference. I'm going to quickly IP this.
Yes, yeah.
I'm going to study IP. Yeah, so One Healthpreneurship. Honestly, there's nothing like that in the literature. It was just my creation to the best of my knowledge, and I think it's going to be revolutionary. It's going to be a movement of social entrepreneurs and people who really want to make impact using One Health. Thank you.
Yeah, thank you. HMRs, you seem to be very interested in the term. And so congratulations to everyone. We are hearing a term for the first time because we attended this event. So that should be enough motivation for you to attend next year. Or when we go physical, it should be a motivation for you to want to come and hear something new. Yeah, it's pretty new. When I saw it, I was also baffled. And yeah, despite reading far and wide about One Health, it's the first time I'm seeing it. But I easily keyed into it because we have to make it make sense economically for everyone. Otherwise, at some point, like you said, no matter how serious your passion is if you're not making something for it, if it's not making impact, it's not making sense. So how would these impacts now be sustainable? The vaccination program I mentioned, for example, if we only depend on donors, government, or INGOs giving us money to buy vaccines or to provide the vaccination services. So what happens after the 1-2 years of the project? But if you find a way to make something from it, and then you can at the very least restock your vaccine and get the little for your service, that is a way to localize or domesticate the concept. But yes, it has to make sustainable impact sense in this time. Sustainable impact, we will not IP that to you because those are not what I had that one from you during my internship. All right, thank you very much. That we have one last question for you. Great presentation. I think including one as an education curriculum for elementary to university is great to expand the scope. What type of work is ongoing on this matter? Well, I must also mention that we have our keynote speakers for tomorrow, our panelists, and other people that can also, answer some of these questions in attendance.
Yeah.
So if anybody wants to take a go on this one.
Yeah, I think it's a good thing. This has to be introduced in I've seen a lot of effort in One Health education, changing or revising curriculums at secondary school and even tertiary institutions. So this is one subject that needs to be introduced or as part of general entrepreneurship or as a standalone course. I think this idea of including it in education of our young people, it's very, very brilliant. And also in platforms where One Health are being discussed. Now we're talking about economics of One Health. Before, like in the past, it was more about just the impact, the science and so on. So I think there's a progress generally around bringing newer, dimensions to the issue of One Health. And so in platforms where One Health is being discussed, in global meetings, I think we need to push for, an agenda on, the business side of One Health. Thank you.
Thank you very much, sir. That was fascinating. We have another question, but unfortunately, we'll not be taking it because we are like 40 minutes behind schedule. So we will take Dr. Lara Khan's video. Unfortunately, she has to travel to another state in the US and she can't be with us. But all the same, we'll be displaying a video right now. And then she has a small gift for us as well, just like Dr. Lian. Dr. Shamsu, thank you very, very much for that amazing session. And yeah, you should look forward to seeing One Entrepreneurship everywhere on the internet, and we'll tag you. We'll make sure we tag you so that they know the origin of the concept. So thank you very much. You can now stop sharing your screen so we can proceed to Dr. Lara Khan's session. Okay. All right. Can you all see the screen and hear?
Greetings, everybody. My name is Laura Khan. My apologies that I cannot be with you live, but I'm happy that I'm able to record this video to present to you. So I'm going to share my screen now. The title of my talk is A One Health Perspective on Food Safety and Security in Agriculture in the 21st Century. Agriculture is the foundation of civilization. Without the ready availability of safe food to eat, many of the things that we take for granted, our cities, our villages, our nations, would not exist because we would be too busy trying to find food. A few definitions. Food security basically means no hunger, and food safety means no foodborne illness. So food security is just a fancy name for not being hungry. And food safety is a fancy term for meaning not getting sick from eating food. This is the One Health Initiative website. Please visit it and tell your friends and colleagues to visit it. The One Health concept that you've been hearing about is very simply that human, animal, plant, environmental, and ecosystem health are linked. This concept provides a useful framework for examining complex issues such as food safety, security, and climate change. And in order to develop effective policies to address food security, food safety, safe and sustainable future, we need to examine these issues in a broad perspective, which One Health allows. And it's important to recognize that people interact with their environment every day by inhaling air, drinking water, and ingesting the plants and animals that we call food. Now, One Health has been visualized in a number of different ways. One way is to divide out the different types of animals, such as livestock health, wildlife health, and human health, all intersecting. That's one way to look at One Health. Another is under this umbrella graphic, where we have individual health, population health, ecosystem health, and a whole bunch of other types of factors that influence the health. There's zoonotic infections or microbes from animals that can spread into humans and back and forth, causing all sorts of different problems. There's chronic diseases, heart disease, cancer, autoimmune diseases that also appear to have One Health implications. Some of these causes, it turns out, of these chronic diseases might have a microbial basis, again, potentially zoonotic diseases. There's the intersecting circles of coordination, communication, and collaboration that One Health requires. Again, humans, animals, and environments. So there's many ways to picture One Health. So in this talk, we're going to have a One Health satellite perspective. We're going to go way up into space and we're going to look down at the planet and assess some of the top issues that are affecting us in terms of food safety, security, and agriculture from a mile-high view. So first, we have to look at the global human and animal populations. As of 2024, there's over 8 billion humans on the planet. And according to the Food and Agriculture Organization of the UN, there's over 30 billion terrestrial food animals. And together, all these humans and all these animals produce a lot of fecal matter. And according to this one paper from 2018, we produce over 4 trillion kilograms of fecal matter every year. Now, how much fecal matter do you think that might be? Well, it's a lot. And to visualize it, think of an Olympic-sized swimming pool. 1.4 trillion kilograms would fill over 1.6 million Olympic-sized swimming pools with fecal matter. Or by 2030, over 1.8 million Olympic-sized swimming pools with fecal matter. That's a lot of fecal matter. Another way to visualize it is burying the entire surface area of Los Angeles and New York City in 6 feet of fecal matter. And we're producing increasing amounts of fecal matter each year. Now, all of this fecal matter impacts food safety and food security and our health. And I'll explain a little bit in a minute. Now, most sanitation systems only address human fecal matter, but there are many countries in the world, including in sub-Saharan Africa, in South Asia, and parts of South America, where people don't have access to basic sanitation. And indeed, over 1 million people are still defecating outside in fields. And all that fecal matter contaminates the soils and the waters and the crops that we eat. So that's a serious problem because all that fecal matter contaminates the food and the water and it gets people sick. So for example, there's lots of dangerous bacteria and other microbes in human fecal matter. I'm not going to read them off to you here, but there's millions of viruses, bacteria, parasites, parasitic eggs in just 1 gram of human fecal matter. So that's a serious problem. In animal feces, there's also lots of dangerous microbes that I have listed here. This is just the bacteria. There's also worms, protozoa, and viruses. But people generally ignore the microbes that are in animal fecal matter. That's usually just not addressed, even though it can contaminate soils and crops and water just the way human fecal matter can. Now, in 2015, the World Health Organization released a report estimating the global burden of foodborne illnesses. And they found that Africa was disproportionately affected by these foodborne illnesses. About 1 in 10 people are sickened by contaminated food each year. Of the 600 million people who get sick, around 420,000 die. And children under the age of 5 years make up 40% of the cases. Now, when you look at the causes of these foodborne illnesses, diarrheal agents cause around 550 million illnesses and 230,000 deaths. And the largest fraction of these agents causing illnesses and deaths are the microbes, the bacteria that are in human and animal fecal matter, including worms and viruses. So all of this fecal matter that we are producing is making us sick. And we need to address it if we want to have a healthier, sustainable future. I'm going to shift gears now a little bit and talk about the environment. Climate, as I mentioned, agriculture is the foundation of civilization. And unfortunately, climate change threatens agriculture, and agriculture worsens climate change. Now, what exactly does climate change mean? Well, in order to truly understand climate change, we need to think like a geologist, and we need to look at the timeline of the temperature of the planet since the beginning of complex life on the planet. So back in the Paleozoic era, when life was first forming, there was lots of life in the oceans, but there was actually very little, if any, life on land. So it was very hot here, but there weren't humans, and there wasn't really life on the land. Now, over millions of years, the planet began to cool, and then you get to the Pleistocene era, where the planet got very cold and was under miles of ice, and that's called the Ice Age. Now, early hominids appeared around 6 million years, almost 5 million years ago. Now, during the Ice Age, people were surviving, but just barely, because it was very hard to find food. Now, about 10,000 years ago, inexplicably, the planet began to warm. And 10,000 years ago, the planet began to have a relatively stable and predictable climate along this baseline, known as the Holocene baseline, which we are living on today. This baseline allowed agriculture to develop and civilization to exist because we could grow our food. It wasn't like the Ice Age, where much of the land was buried in ice and people were struggling to survive because there was no food to grow. So along this Holocene baseline, there was a little blip below the baseline called the Little Ice Age. And during that period of time, like the Big Ice Age, crops weren't growing and people were starving, and there was lots of famine, and wars broke out and civilization broke down. Fortunately, the temperature went back to the Holocene baseline, and agriculture and civilization could continue. But unfortunately, with climate change now, we're starting to deviate off this Holocene baseline to we're now about 1 degree above the Holocene baseline, and we're starting to see a much hotter planet with severe weather, which is going to impact agriculture. So now, why does agriculture impact climate change? Well, agriculture produces a lot of greenhouse gases. Cattle and other ruminants produce a lot of methane when they digest their feed, and they burp the methane out. Methane is a very potent greenhouse gas that traps heat in the atmosphere. So when you have millions or hundreds of millions of cows burping methane, that's going to have a global impact. In addition, remember all that fecal matter that I told you we're producing? Well, that fecal matter also produces methane and nitrous oxide. Both are extremely potent greenhouse gases that are trapping heat and making the planet hotter. In addition, nitrous oxide, we use a lot of high nitrogen fertilizers in the soil. And when that soil is tilled, it releases this fertilizer into the atmosphere. So these are all great sources of greenhouse gases that are contributing to the heat of the planet. They're about almost a quarter of the greenhouse gases, and they're very potent. Now in 2010, the World Bank estimated what the agricultural yields for the planet would be in 2050 due to climate change, if assuming that our agricultural practices and the crop varieties that we use remain the same. And they found that much of the planet, all here in red, is going to see severe reduction in the production of crops because of climate change. So it's much of South America, much of Africa, Australia, South Asia, a lot of the United States are going to become too hot and too dry to grow food. Northern Canada, Northern Europe are going to be the producers of food, assuming that their soil is rich enough to support agriculture. So this is a serious problem for all of us as we face the future of the 21st century. Now, as it is, we have a lot of food insecurity or a lot of hungry people in the world. This is a World food map or food undernourishment map put out by the Food and Agriculture Organization averaged over 2021 to 2023, the amount of percentage of undernourishment, it's a 3-year average. And much of Africa is hungry. And this is before climate change has really kicked in. So this is a major issue for the continent of Africa now and for the decades ahead. We really want to try and keep as close to the Holocene baseline here as we can, so that we don't become so hot that we can't have agriculture or civilization. Currently, our current policies have us increasing our global temperature by 2.7 to 3.1 degrees. Right now we're at 1 degree. So we want to try and have pledges and targets that keep us as close to this baseline as possible so that we can continue to grow our food. So remember, I said agriculture is the foundation of civilization. Food security means no hungry people, and it's built on 3 pillars: food availability, food access or affordability, and the use of food. Food security is so important that the United Nations listed zero hunger as number 2 of its Sustainable Development Goals. And indeed, many of these Sustainable Development Goals are amenable to a One Health approach, including good health and well-being, clean water and sanitation, among others, climate action. Now, meat, or the ruminants that I talked about that are producing all that methane, and the animals that are producing all that fecal matter, because there's over 8 billion humans, we're projected to go up to maybe 10 billion humans. People want to eat meat because we want the meat for survival, sustainability. Now, we don't need to eat meat, but people like meat. And the global meat production has gone way up to meet the global demand. Now, Africa's not here because Africans don't eat as much meat as in other parts of the world. So, but in many parts of the world, eating meat is the norm almost everywhere, with the exception of India, where there's a large fraction of vegetarians. So our One Health analysis then that we've been talking about is human and domesticated animal populations are growing and producing increasing amounts of fecal matter each year. Animals produce about 80% of the global fecal matter, but it's generally ignored, both in terms of the contamination of the soils, the crops, and the water, but also all of the production of the greenhouse gases that it's producing. Human and animal fecal matter both contain many pathogens or deadly microbes, but sanitation systems, if they exist, are designed to only process human waste. Ignoring the animal fecal matter can contaminate food and affect food safety. Manure management and agricultural soil management emit methane and nitrous oxide, which are both very potent greenhouse gases, into the atmosphere, worsening climate change. And these findings impact food safety, food security, and agriculture. Now, in terms of One Health, because of food contamination, people get sick, and then they start using antibiotics to try to get healthy again. And as we use more and more antibiotics, we have the problem of resistance developing, in that the bacteria become resistant to the antibiotics. So the UN General Assembly has announced that antimicrobial resistance is a global problem, but they do not mention the impact of manure, of all that fecal matter that we're producing that contaminates our soils, our food, and our water, that makes people sick. So one of the most important things that we need to do is we need to clean up our environments and our ecosystems of all this animal and human fecal matter. Now, the UN, the COP UAE, has recognized the importance of food and agriculture on climate change, and at least recognizing the problem is the first step in addressing it. So to sum up, we must protect our beautiful planet if we want to continue to survive on this planet. And One Health recognizes that life is interconnected. So what can you do? Well, you can learn about One Health, and I'm delighted that this workshop, this conference exists. You can help spread the word to your family and to your friends. Develop interdisciplinary colleagues, people with different interests who want to work together to address these problems. Organize and be change agents and create One Health clubs. Now, I've given you a lot of numbers and statistics on some of these 8 issues regarding food safety, food security, and climate change. If you're interested in learning about it as a story, I've written a science fiction novella called Thorns, When Earth Refugees Are the Aliens. I'm happy to send a PDF of the story for you to learn about these concepts in a perhaps more entertaining way. Just contact the organizers and I'll be happy to send them a PDF of the story. So I'd like to acknowledge my colleagues in the One Health Initiative. Our team was co-founded in 2006. We have our website here that has been in existence since 2008. And I'd like to thank you all for your time and attention. I'm sorry that I'm not with you to answer any questions, but if you send me an email through the organizers, I would be happy to answer any questions that you might have. So again, thank you so much for your time and attention, and I applaud the efforts to learn about One Health. Thank you.
All right, that was fascinating. I find it very interesting, as interesting as the physical, I mean, the presenters that were available. Thank you so much, Dr. Lorraine and Absentia. So like she said, if you have questions, please type them in the chat box. We'll compile the questions and send it to her, and we'll also relate responses to y'all. Yeah, I mean, we would have thought fecal matters had so much of impact on One Health, if not for this presentation, because of course there is so much that is still been neglected, and when we're talking about One Health, you're talking about everything, and that's also a problem because it's difficult to capture everything. So now is the time for the breakout session, and we will share the link to the attendance for today before we go into the breakout sessions. However, the breakout session will take 15 minutes here to discuss about the topic that will be posted, and you select someone that will present on behalf of your group tomorrow. Sorry, we're a little bit faulty on time management today. It won't happen tomorrow. We'll make sure we keep the time and we'll finish right at 11:15. It was scheduled for. So my colleague Johnson will share the attendance list in the chat box right now. And the last question is, do you want to receive the book that Dr. Lara mentioned? If yes, then you send it together with the package that you will receive, all the presentations, the videos, and we'll send you a YouTube link to the recording of all the sessions from today and tomorrow. Thank you very much. It's time for breakout. Most of you must have received, or all of you must have received an email indicating the group that you are in for the breakout. And if not, just feel free to join any of the 3 groups when the breakout is started. Thank you. Dulcie, it's time for you to take over. Just please send the attendance form in the chat box, and yeah, the breakout session can commence.
Okay, thank you everybody for staying through with us even down to this time. Like Dr. Dowda said, we apologize for taking a little bit of our time. Yes, the attendance has been sent to the chat box. You can please just register and let us. The essence of the attendance is for us to be able to send out your certifications after the conference, and also for the breakout section, let it just be for 15 minutes, wherein each group should discuss between themselves and elect a speaker you're going to present what you've discussed at the end of your breakout section, at the end of your discussion tomorrow. Thank you, everybody. Dr. Dauda, we can go for the breakout section now. Thank you.
All right. The rooms are open. Are you all able to join, or do I need to sign?
Okay, I'm doing that. I'm assigning as many to case study group.
All right, let's have an even assignment, like 15 in each group or up to 20.
The breakout section is also an opportunity for everyone to, interact with one another. It's a smaller group. You get to know each other even way beyond the conference, and from there you can network better with one another.
Yeah, hello. Someone from here called for help. All right, so what is going to happen here in the next 15 minutes is I will share a topic, and you will all, this is breakout room 2. I will share your topic right now in the chat box, and you can discuss about what is being shared. Just a second. All right. Can someone unmute this? We can drive the conversation. Do not worry if you've been sent to a different group. It's just for interaction purpose. But if you insist, we'll send you to the group that you received by email. Thank you. I will step out now. Please make sure the conversation is an interesting one. You have Marilyn here and Eunice. They might assist you further. All right. We have unassigned participants here. Hello. This is case study group 3. Please, the last link that I sent in the chat is for you. Check the case study there and have a discussion.
The Ministry of Health of Okay, the Ministry of Health of Wakanda sounded the alarm after witnessing a rapid increase in drug-resistant infections in hospitals. They have realized that there is almost an AMR outbreak in the hospitals. So they have sounded an alarm. Report shows that treatment
Can someone assign us to rooms, please?
Hello, everybody. Yeah, we have come to the end of today's conference, and we're so sorry we took a lot of time, but we appreciate everyone's efforts to, discuss within the groups and come to a conclusion concerning their case study. I hope everyone has elected a representative for each group. Can I have somebody from group 1 on mute and let me know if you already have someone to represent the group tomorrow? You can raise your hand, I would unmute you. I think the Marilyn Muti, you were in group 2, case study group 2. I'm going to be unmuting you. I hope we've arrived at a conclusion as regards who is going to be presenting for the group. All right. Let me unmute. Hold on. Sorry if I didn't get the pronunciation of your name. Okay, you can speak now.
Yeah, just to ask you when we have to finish, because I guess it was planned until 12:30 Cairo time, and now it's 1:10 and I have another meeting.
Yes, we are.
Right? Sorry.
We apologize for taking so much of our time. The discussion took a lot of our time. But we're ending the conference right now. We're ending the conference in the next 2 minutes. We're ending the conference, but I just want to be sure that every group has a representative for tomorrow. Dr. Marilyn, I know you're in group 2. Can you please let me know if your group has a representative for tomorrow?
Yes, hi, Dancing.
Hello.
Yeah, we have 3 presenters. We have 3 discussion points, and we have 3 people that will be representing us tomorrow.
Fantastic. Thank you so much. So for group 1, can I get the feedback? I just need a feedback. I have a feedback from group 3 already. Can I get a feedback for group 1? And we'll bring this section. Okay, I think I can see in the chat box. All right, thank you. Is that for group 1?
Yes, Dr. Abdurrahim will do.
All right, thank you so much, everybody. And we've come to the end of the conference. I hope we all learned 1 or 2 and enjoyed ourselves. So we'll see you tomorrow, and we would keep to time tomorrow. Thank you so much. Before you go, ensure that you register for today. It's important for your certifications. Ensure that you register. Thank you so much. Yes, the materials will be shared tomorrow after the conference. The materials will be shared after the conference first. Thank you, everybody. Have a nice day.